All right, so one of the considerations that I'm going to be doing is just checking for nasal gastric reflux, and if it is, and there's fluid over there, and it's a copious amount of fluid. We're talking anything like 6 liters plus, and probably we're gonna have to refer you for surgery. 8 liters. If we're just getting 1 liter, a couple liters, we're gonna check it and be sure it's not like it's stinky. What kind of color is it? And if there's less than a liter or just a little bit, we're gonna start hydrating this patient. We're gonna give him a little bit of water with a lubricant, mineral oil in there, and we'll start pumping the inside just to see if we can start helping with that. Also, we can add some electrolytes to start helping your horse with that. But yes, as I said before, we're gonna be checking for odor, quantity. Be sure that nothing is looking horrible. As I said before, less than 1 liter will be enough. Also, at the same time that we're checking his mouth for feeding the tube, we're gonna be like checking his gums and be sure that there's no any signs of possible shock, right? Either being hyperemic on the gums or be all dehydrated or tacky, highly dehydration. Let me tell you something. If we have anything above like 2 liters and this fluid is coming in yellowish, reddish color, I'm not gonna give you anything really, and I'm just gonna refer you for surgery pretty much because that's concerning thing. If we're bringing more than 2 liters out, forget it, man. That's a lot. So I'm just gonna give him the pain medication and gonna chip you out of here to the surgical hospital. Another thing that I can do now, since we're having sedated and we're already past the NG tube and we're seeing that there's a little bit of fluid and there's a little bit of distension of the abdomen, it'll be the possibility to get an abdominal sample in case that this is just getting worse and because of this amount of fluid that is coming out of his belly, maybe he already ruptured. I'm concerned because his gums are looking pretty tacky and his heart rate is over 100, so this is not an easy situation. So, hey, come by here, friend. Sorry. So the other thing that we can do is I can just palpate him down the midline of his abdomen. Let me get close to his shoulder. I'm gonna run down my hand down his belly, and I'm gonna go all the way to his sheath. I'm feeling the sheath, and then coming back to the sheath on the midline, and then I can feel the umbilical. So now that I found the umbilical, I'm gonna move like 4 inches away from it cranially, and then I'm gonna move 4 inches to the right. This is gonna be a best spot for us to start considering doing an abdomen synthesis, just to find out if this guy didn't rupture anything. Because if he didn't rupture anything, man, you need to run for this fucking surgery. So first thing we're gonna do is we're gonna clip a little bit around the area where I just described it, and we're gonna clean it up a little bit. Surgical scrub, 1, 2, 3, 1, 2, 3, 1, 2, 3. We're done with the scrubbing. And then on that spot that I just described, 4 inches away from the umbilicals going cranially and 4 inches away going to the right side, we're gonna be either using a little bit of lidocaine to do a bleb, and we can do a bleb all around, circle around, pretty nice bleb. And let it sit for a few minutes, let it cook for 5 minutes. Once we're done with that one, then we're gonna use a knife, scalpel blade, and the scalpel blade we're gonna do a little cut through it. And almost like cutting through the linea alba, just go straight up, hold the blade with your fingers, the whole blade, just let it be like maybe allow like 15 or 20% of the blade in. And once that you have it in, you're gonna either feed needle, which could be a larger needle, 18 gauge by 2 inches, or you can either use teeth cannula. I prefer teeth cannula because the tip is round, so there's less chance to perforate spleen. And we're trying to do this location because we're trying to be away from the spleen. But in case something happened, we had to do that just carefully. So once that we have that one in, we're gonna find out if fluids are coming down. If it is the case and fluids coming down, we're good because we need to start collecting all the fluid so we can start working out. And once that we have the fluid in, we're gonna be collecting those samples, and we're gonna take a look at those samples and be sure that there are no like any type of fluid in there, any color in particular, any serosanguinous color. Forget it, man. You have to go to the hospital as soon as possible. So this is basically just to be sure that there's nothing major going on. So as said before, it's pretty much abdominocentesis. So be aware of that. One hand behind the sternum and the xiphoid, and hand to the right, avoid the spleen, which is the most important part. So normal fluid should be like just pale to yellow color. If it looks serosanguinous, as we said before, we're going straight to the hospital. Now, let's say that we don't have that much fluid and we didn't have the need to do the abdominocentesis, or we did it and nothing came out. I think it's your horse is responding now that are giving the pain meds. Because these pain meds usually last like 30 to 40 minutes, and it's been like an hour doing all these things. And they should be worn by now. They should be worn off by now. So it looks like your horse, it's more calm and it's coming back to normal. So I think at that point we can consider to do some medical management, because his heart rate came down. He's been responsive to this. We can maybe give him some buscopan. So surfactant medication is something that we can give in also to go. It's going to help you to break down the impaction. Usually breaks down the gas bubble, so it's pretty useful for tympanic colic, right? Or spasmodic. Tympanic or spasmodic is the same thing. That's something that you can consider. Also, a little bit of mineral oils, as we told you before, electrolytes. Some veterinarians, they use magnesium sulfate. I typically don't like it because it causes too much diarrhea. So you have to be careful with magnesium sulfate. But it's a possible too. So with the medical treatment, basically, we have to be sure that there's diarrhea, gastrointestinal sounds will be increased, fibrinogen will be high up, and pain will be mild. So let's get a little bit of blood. Hey, what's your name, Victor? Get some blood from the horse and run me a fibrinogen test, okay? I need that one running now. So, as I told you before, a little bit of pain medication. We're going to give you also butorphanol and flunexin megalobin, buscopan as well. That's going to help us as well. Maybe hydrate MPO, as I said before. We can also do a rectal exam, but I don't know, we push much in the boundaries too, because this is going to cost you like 2Ks already. If we're seeing that there's no response with all this treatment that we're doing right now, and he's still like bringing stuff out, then basically we're gonna have to stop the medication and send you for surgery. If my reflux over 2 liters on this test I'm gonna be doing is more than that, then refer you for surgery. If my lactate is coming up, refer you for surgery. If fibrinogen is coming up, refer you for surgery. So everything depends on this upcoming testing. So if you like to leave your down payment, it's going to be $2,000 for this case. So, and I'll call you later whenever I'm done with everything. All right. Thank you, sir. Have a good day. All right. We're back. So the next thing that we're going to be talking today is going to be about equine uroperitoneum. Basically a condition that we're going to be seeing in foals most of the time, because it's a uroperitoneum, right? It's like a stalk. It happens a lot, mostly in newborns, foals. So one of the considerations with type of disease is going to be ruptured bladder. So anytime you see a foal that's having issues to urinate, stranguric, and the belly looks a little large, maybe plus minus a bit of patient urachus, you know that there's a possibility of ruptured bladder. There's a possibility of uroperitoneum in there. Just kind of like happening within the few days of life, as we said before. It's pretty much newborns. And ruptured urachus, one of the main names. Usually, if precedes to secondary infection, And the first thing that we had to do in this case is just grab the ultrasound. So you're seeing this horse. This call is doing kind of weird. Hand me the ultrasound. We're going to do a little checkup here. So bring it over. Place your ultrasound probe under. Look at it. Find out if there's any hypoechoic fluid in there. Any black, and you know that there's fluid. We're ready to go. Differential diagnostics on these cases, basically elevated creatinine and fluids versus serum is pretty important. Typically, you can measure the serum or the fluid. In that case, you can do abdominocentesis and just get a little bit of the fluid. You can spin down and run a creatinine on that one, and also you can run down your creatinine serum. Is this 2 times full of what you're obtaining out of the abdomen? Certainly, you're dealing with a uroperitoneum. A patient is going to be azootemic. And one of the main consequences of rupture bladder is going to be a high potassium because you're not able to excrete it. You're not able to excrete it. You're not able to excrete it. You're not getting. You have a way to get rid of the potassium out of your system. So be aware of that. And then you're going to have also dehydration, right? You're going to have decreased chloride and sodium as well. So basically, treatment, first of all, evaluation of the fall overall. Be sure the patient is stable. Patient is not stable. The first thing that we have to do is decontaminate the area, of course. So we have to drain the abdomen. We have to give him a little bit of fluids to hydrate the patient. If the sodium is too low, we don't want it to be hyponatremic, we don't want it to be hypochloremic. We have to control the potassium if the potassium is too high as well. And of course, we don't want it to add any potassium in there, but what we want to add is a little bit of dextrose to help start mobilizing all those potassium electrolytes within the cells. And also insulin as well. Giving dextrose and insulin together to start moving the potassium back into the cells. And stabilization, basically. Drainage, pain medication. And then from there, we're going to move to a surgical repair. Open it up. Find out where's the patient urachus. Closing it up. And if everything goes accordingly and there's no sepsis and mostly everything looking good, we can flush and clean the abdomen, start patient antibiotics, close the bladder pretty nice, and then certainly we can consider it will be a good prognosis in this case. But certainly we have to be careful and we have to be sure that all this, it is just where we're thinking and there's no extra complication in these cases. So be aware of that when you're working with this type of cases, pretty important. All right, we're back. So now we're going to be talking about something that's pretty important and pretty common on young horses, older horses, or any horse that is supposed to be mingling with another horses. Mostly show horses, I would say, is one of the main things with this type of disease. Horses that are traveling, going to affairs or any type of shows, they're always exposed to this because they're going to be mingled together. You don't know who's sick, you don't know who's right. The cherry things around, and this is a pretty high contagious thing. So today we're going to be talking about strangles. Strangles, it is basically bacterial infection. Pretty bad bacterial infection. The known factor on this type of condition is called beta hemolytic streptococci. So the beta hemolytic strep, in other words. And with this one, we're going to know the transmission is going to be basically nose to nose. It can be all the way around in the same area. It could be also aerosols. It could be also fomites. That's something that is going to be on the environment, right? The horse is in a show. They're sharing buckets. They're sharing utensils, things like that. And one of the main things that we're going to be seeing on these guys is just the presentation. So all the time, I would say 90% of the time, strangle cases, they're going to have fever, okay? The patient is going to look a little bit depressed. And one of the main things that we always see on the strangle is going to be, patient is going to be pretty depressed. That's one of the main things, depressed. Typically happening on a younger age, mostly like 1 to 5 years old. It's pretty common. And what we're seeing this type of disease, there's a major indication in this condition that we have to keep in mind, and that's going to be the development of extra large hypertrophic lymph nodes. And we're talking the submandibular, we're talking the sometimes sometimes it could be in the prescapular, but not all the way over there, but mostly mandibular and submandibular. Those are the main ones. So yeah, be aware of that because it's either pretty large. The patient is going to be a little bit dyspneic. It's going to have a little bit of cough because of the same enlargement. Some patients might have some discharge. And then the thing with this one is like they are so swollen, the airway could be compromised in some cases. So we have to be pretty careful with this. So first thing we had to do is isolate this patient. That's super important. Super important. Isolation. If you don't isolate the patient, you're going to have issues. You're not going to let this guy to be mingled with the other ones at home because then this is going to pass all over. You're going to have multiple cases. So isolation is going to be the first thing. The second thing with this type of condition, it'll be, beside the isolation, is to start doing a little bit of sampling. Typically, what we recommend is a swab of the drainage. And when I'm talking about drainage, is because this lymph node, they get so enlarged and so thick, they're going to be showing some sort of discharge at some point. At the initial phase, it's just high temperature with a lymph node hypertrophy. But after lymph node hypertrophy and enlargement, we're going to have a phase where we're going to be seeing a little bit of rupture. And that's a mature phase. That's when actually the organism is coming out to the environment. And that's a most contagious phase too as well. And of course, in that moment, when we're seeing this start flying out, that's when we have the chance to start collecting all these fluids in there. And we can send it out for either a culture, we can send it out for a PCR looking for strangles. We can do our swab out of that one. Differential diagnostics for these conditions, it will be facial abscesses for another reasons, right? Or any viral respiratory disease will cause hypertrophy of the lymph nodes. Although not all the upper respiratory will cause the lymphatic tissue to start breaking down apart and start bringing exudate out of there, unless it's a pretty bad one and nothing can there. So treatment on these guys, basically everything was going to be support treatment. Antibiotics is a controversial thing. Some veterinarians, they use it if they have like a persistent fever and it's not getting well. Most of the veterinarians, I would say 90% of them or 90% of the cases are cases that they can be controlled. As long as the patient has a patent airway, it could be controlled with non-steroidal anti-inflammatory. Flunexameglobin, I think, is a good one on these cases, which is going to give you a good pyretic control. And besides the pyretic control with flunexameglobin, also hydration is pretty important because this disease can make them dehydrated too. So in some cases, we can actually give an IV support. And something that you have to always remember, and super important, isolation, you need to have 3 negative PCRs before this guy goes to mingle with someone else. So this can take like a month easy on isolation or plus. But at least you have to have 3 negative PCRs. So I would recommend you start with the initial baseline, then a couple of weeks later a second one, then a couple of weeks later after that do a third one. So that's the way that you can have 3 negative PCRs and you're not have any issues with this guy. So keep that one in mind. And as we said before, be sure that there's no extra complications. The way to prevent this, it'll be basically vaccination. Some cases we recommend to do the strongest vaccine. Not all the veterinarians they do because it's not a core vaccine, but at least we know when we have strangles, the patients are going to be exposed to it. And if the patient is going to be exposed to shows or fairs, going places where there are going to be a large amount of horses and crowded areas, I will definitely recommend to keep it in your radar as a possible vaccine So it's a risk-based vaccine, pretty much. Risk-based vaccine. Modified lice vaccine can create an abscess with other vaccines if given alone, so keep it in mind. And one of the worst complications of this, it will be a type 3 delay reaction, which will be purpura hemorrhagica. And that's one of the ones that I'm always concerned about it, purpura hemorrhagica. Usually you see a pretty bad vasculitis. It can happen on the forelimbs. It can happen on the rear limbs. Of course, we're expecting not to see that, but sometimes this kind of toxins that are caused by this beta hemolytic strep, it can get in there, so it can get a little more challenging. But that will be a pretty bad complication. So, as we said before, most of the time just allow the access to break naturally, given non-steroidals, control fever, hydration, be sure patient is sitting, is comfortable, and responsive to treatment as long as it's draining and the airway is not compromised, able to breathe. It should be good to go, and just continue with his treatment and his regimen and wait for the course of the disease and be sure everything is maturing normally. All right, thank you very much. We'll go to the next one. All right, now coming back with another respiratory disease. We have another respiratory disease, and we have Rhodococcus equi. Rhodococcus equi, usually, again, as we talked before, strangle is something that we just talked recently. It's a disease that's seen mostly on horses less than 5 years old. And this guy on Rhodococcus equi, we're seeing this one in foals, but younger foals. We're talking anywhere between 2 to 6 months, okay? So keep that one in mind, 2 to 6 months foals. Basically, it is caused by a gram-positive bacteria, typically a transmission by inhalation, and it creates pretty bad pulmonary abscesses. That's the main thing with this bacteria, because I wish this disease, the Rhodococcus equi, just stay on the upper airway and just give some antibiotics and go on with this. But unfortunately, it's a pretty bad bug because it has affinity for lung tissue, and colonnadium, what it is, the lower tract disease, oh my God, it makes abscess in there. It makes pretty difficult because the consequence of this is going to be a chronic pneumonia. So pretty bad pneumonia and falls pretty much. So you always have to be pretty careful about medications, about treatment with these conditions. Some cases, when they get worse, beside the extra pulmonary involvement, right, you can have things like ulcerative colitis. You have sepsis or non-sepsis, which could be arthritic septic or non-septic. And also you can have a spinal abscess, which will be a pretty bad condition. So that's when it's really like spreading all over. So diagnostic for this type of condition, we're gonna consider first ultrasound, pretty important for Rhodococcus. Lately we've been using ultrasound a lot because, getting easier and cheaper. And radiography as well, if you are able to. Another thing that we can also do, it will be a transtracheal watch to collect a sample, and of course our physical exam, right? Pretty valuable physical. Looking at your lung fields, listening at your lung fields pretty well. Look at the patient, be sure that there's no like a high fever or chronic pneumonia. So you're gonna have to look mostly on the cranial-caudal lung fields, which is basically the area where pneumonia sits. So cranial-caudal area, more focus in there. But check out your parenchymas on the lung. The horse has like up to 18 ribs. So basically, I would say like anywhere between rib 1 to rib 11, 12. Those are where we have all the long parenchymas. And usually places special focusing on anywhere between rib 1 all the way to rib 7, 8, which is on the lower quadrant, which is basically a typical area for pneumonia to start building it. So if we have crackles, you have crackles going on, spec pneumonia, we need to start treatment right away. These folks can go quick, you can die. So besides giving a little bit of supportive treatment, which it could be oxygen in these cases, because airway is compromised. You can check SpO2 and be sure where we're at, but if we have trouble, we can give in oxygen. We can also give in non-steroidals as well to help with the inflammation. And we need to start with erythromycin and rifampin. This is a good combination. The only thing that we have to be careful is these falls, since they're a young age, they can be around the mare. So it is reported the erythromycin can cause fatal death on mares. As we know, that's something that we don't use in large animal, completely prohibits for older horse. We don't want to kill the mare, but just for being around, they can be in contact with that, so we have to be careful with that. Also, we can use clarithromycin as a second option. We can use azithromycin, but basically supportive care and just try to get away with this. Some falls they will die depending how much is colonized, depending how much of this inflammation is going on. But some they will make it depending on the response of the treatment and the supportive care. All right, thank you very much. We'll see you in the next one. All right, so we're back here, and today we're going to be talking about COPD, hives, respiratory airway obstruction. So pretty much all these three are exactly the same thing. So it's just like old terminology, a new terminology, somewhere in the middle. So we are considering this type of condition happening in patients that are typically older than 10 years old. So a patient that older, COPD, recurrent airway disease, obstruction, or hips, right? Hips. The name hips, it comes actually for the hip line. And the hip line, which means is basically the marking of the intercostal spaces anytime that the patient is breathing. So this dyspnea that is caused by possible allergens, which is most of the time, it causes excitement of the neutrophils. So actually it is reported that mostly of these neutrophils on BAL, right, or bronchoalveolar lavage, more than 20% on the BAL and seeing non-degenerative neutrophil is pretty indicative of this type of condition. So the situation here is like anything that is affecting the horse, either mold on the environment, allergens on the environment, any endotoxin on the environment, is going to cause this excitement of neutrophils, and then as a consequence, we're going to have this respiratory distress in some way. So those patients are going to have exercise intolerance. The patient is going to be wheezing when we have a little bit of the airway obstruction. We might have mucosity, we might have flare, trying to catch more air. And of course, as I talked before, the hip lines are the most common pathology of this. The most common sign of pneumopathology here, where we are facing these situations with hips or RAO or COPD. So one of the things that we had to consider as a differential diagnostics on this condition for hips or recurrent airway obstruction, it will be pneumonia. We can also think about silicosis toxins. We can think about neoplasia, and we can think about bronchitis. So those four are our main differential diagnostics: pneumonia, silicosis, neoplasia, bronchitis. Pretty important things to keep in mind on those cases. So treatment for this type of conditions, the chronic condition, as we talked before, less dose environment. So look around, see what's going on. Where is this horse living? What is his condition? And also check for possibility of start giving a little bit of corticosteroids. We can even give it in a spray. Typically giving injections works better. Or you can continue that by mouth in a short dose, either prednisone or dexamethasone. Bronchodilation is another thing that we're using lately a lot, so consider your terbutaline as well. And interferon has been studied as well for these conditions. Mostly in another condition that we're going to be talking in a second, which is the inflammatory airway disease, or IAD. All right, so speaking about inflammatory airway disease, on this one we consider mostly some hyperreactivity. It's a little bit of cough, it's a little bit of nasal discharge, it's a little bit of small airways, it's a little bit of hyperreactivity. So that's pretty much what we're seeing with this type of conditions. So it's kind of like same version of this one, but you're seeing a little more cough and more reactive. But pretty similar at the end, pretty similar. Also, another thing that we have to consider when we start seeing any of those airway diseases with blood involvement, either we have a pretty bad sinuses going on or something else is happening. Mostly for race horses that are healthy and not having any issues, they're not old, they're still young. And if we start seeing any epistaxis on those guys, definitely 100% of the time related for rupture on the pulmonary capillaries or capillaries on the nasal parenchyma, pulmonary trauma because the race horses, equine pulmonary hemorrhage. So we have to be careful with induced pulmonary hemorrhage, EIPH. Equine induced pulmonary hemorrhage is one of those conditions which is greatly seen in horses, and as I said before, it's always going to be related with things like extraneous exercises because of the running and the betting money and all these people exploiting these poor animals. So unfortunately on these guys, this being widely known, mostly at the racetrack, they start putting on furosemide. Actually, it is allowed to do this, and even on the racetracks, and they can do it like hours before the competition, like 4 to 6 hours before they're giving their injection. They start running those poor guys over there. But it's not normal. Don't do it. Don't work for these people, and these people are bad people, so don't do it. So be careful. So that will be pretty much for this condition. So we'll see you at the next one. Let us know. Thank you. I forgot to tell you guys, if we don't see any mast cells, if we start actually seeing mast cells on the BAL, it means that condition for being neutrophilic now is worsening into something more deep. So that would be like not responsive to treatment. So that would be a more concern. So keep it as a note. Thank you. All right, we're back here and we have gastric ulcer today. So we're going to be talking about gastric ulcers. So keep it in mind because gastric ulcer can be considered also one of those causes of colic, right? Remember, that's considered under the inflammatory colic. So we're seeing it today by itself. So basically, some cases they don't have any clinical signs. Remember, just for anatomy concepts, the esophagus in the horse, the 30% of the esophagus is smooth muscle, and the other 60% is pretty much striated muscle. So we have two types of muscles right there. And once we got on the stomach is divided in two parts. One is the glandular stomach, and one is the non-glandular stomach, which is going to be the squamous cell stomach, right? Or squamous cells in that location. So basically, on the glandular stomach, that's when we have all the creation of this gastric acid. And we have right there the division in between them. That's called the Marcus plicatus. And that's what it happened, when we have extra secretions and for some reason something is happening, we're going to have issues going from the glandular side to the non-glandular side. And that barrier that is in between, it gets broken down. And for some reason, all the acidity of the stomach ending going to the non-glandular area. And that's basically when we start seeing our ulcers. So risk factors for gastric ulcers, as we talked before, it could be a stress, big strenuous exercise, Concentrated diets, that's a big factor. Keep it in mind. Typically, those diets, it causes a lot of acidity in the stomach. And then the indiscriminate use of non-steroidal. You want to use it all the time. You want to use it for this. Using bute by mouth, that's a problem. So keep it in mind. All right. So clinical signs. Basically, most of the horses, they do not have clinical signs, although they could be a little bit anorexic in some cases. On falls, they're more susceptible. You can see a little bit of bruxism, which is just the grinding of the teeth, right? And that's pretty much it, right? So remember, squamous glandular mucosa, moracid, as we talked before. Differential diagnostics for this one is going to be neoplasia of gastric origin or another type of infection on the gastric mucosa. So the location typically for gastric ulcers, as we talked before, a little bit of anatomy, squamous mucosa of the lesser curvature, just proximal to the marcus plicatus. So the squamous mucosa of the lesser curvature, just proximal to the marcus plicatus. Remember, this is pretty much our division into the glandular and non-glandular area. So, treatment, we need to protect. The only way to protect an ulcer, omeprazole, is proton pump inhibitors. We can also use ranitidine, H2 receptors, start lowering a little bit of acidity. Try to have a less stressful environment. And also, we can also, for those glotted patients, we can offer small meals rather than do like a large meals all the time. So consider small meals all the time. And we're going to be also keeping in mind the non-steroidal anti-inflammatories, as we said before, bute. They're always in charge to inhibiting the cyclogenase. And of course, the problem here is they usually does the number COX-1 and 2, and COX-2 are the bad ones. So you have to be careful with those because if you're giving medication who is inhibiting COX-2, then you're going to have problems. So most likely something that you have to keep in mind with your treatments. But unfortunately, it's pretty widely used in horse medicine for other concurrent conditions. All right, thank you very much. And that was the talk about gastric ulcers. All right. So we're going to be talking about severe lameness now. We have talked previously about lameness. We talk about different type of causes of lameness. We talked previously about the endocrine, support limb, inflammation, lameness, traumatic, soft tissue. And we talk about observation. We talk about different grades of lame. Also a little bit about the possible ways to work out the leg, which will be the neuroleptic anesthesia or medications to block the nerves. So now we're going to be talking about severe lameness. When we're talking about severe, we're talking anywhere between 4 to 5 lame. So as we discussed on the previous talk, we talk about the grades going all the way to 1 to 5, right? And 5 being the ones that they are not bearing weight, and we're concerned about more than a fraction that actually lame, and we recommend actually not do too much on those cases until we have bigger diagnostics. And then 4 is the same thing, something that is just visible. He's just walking and limping right away. So 4 to 5. That's where we are with this. So pain is going to be one of the main things, and you're going to see that one pretty good. And I would say, like, if you start seeing this type of things happening in a horse who lives in a fracture, the first thing that needs to come back to your brain, it is a fracture. The horse lives in a pasture. There's a possibility he'll fracture itself overnight. They call you early morning saying the horse is completely lame. They don't know why. Fracture will be the main thing. So, the first thing that we're going to be starting is, first of all, trying to localize and see if there's any fracture going on, which will be one of the things. But also we have to do another considerations. But as I said before, 90% of the time on a 4 to 5 lane, we're always concerned about fracture. So if it is a possibility of fracture, x-rays will be your first thing to consider. Now, supposing that there's no x-rays available because we're in the field and there's no x-rays, the only thing that I'm going to recommend you in those cases will be pain medication and bandaging the limb immediately, just in case. Support limb bandage. That's the most important part. Stabilizing the leg and giving pain medication. We need to do that. Then we're going to have to move into another facility. We can investigate more and do the radiograph. If we find that there's a fracture going on, you have to always consider that most of the fractures are metacarpals. So it's a possibility it could be over there, but also there's another possibilities as well. And of course, we're talking about a closed fracture because it's something that is not obvious, right? But splinting is pretty important, and pain medication, palpation, as we talked before, and then start moving from there. Now, other things that can cause also severe lameness pain from 4 to 5, from one day to another one, besides fracture, as we considered before, it'll be sole abscess. Sole abscess seem to be pretty painful, really, because the all the way in the base, you're bearing all your weight on that sole, and certainly anytime that you move, it's like, ouch, ouch. It's like your feet, ouch, ouch. You have something on the plantar area of your feet, right? Something going on the plantar, which will be in the back in the horse, but in the humans, the plantar is your feet. So it'll be painful. So if we end up having anything like a sole abscess, of course, hoof testers will be indicated in those cases. Digital pressure is something else that we can check just to be sure there's no high temperature around it. And most of the time related with rain or any type of sole that is all soft because it's been sitting right there in water or in a moist environment. Remember, black walnuts, those are terrible, terrible, terrible to put as a bedding. And then can create bacteria start moving, and then of course we can have issues with that. So another consideration. And the third consideration we can have, which can happen usually at the joint area, particularly the pastern joint, which is one of the most common ones. It will be a septic joint. It could be any joint actually, but not that one in particular, but that's the one that we're always targeting. So septic joint, it can happen. If we end up having anything like that, we're going to have to do a little bit of confirming pretty much. We can do a synoviocentesis. We have to be careful if there's any cellulitis in order to do that. In some cases, we can do a little bit of lavage, arthroscopy. We can do systemic and local antibiotics because that's pretty important. You know, if you have an infection on your joint, you don't want it to start moving everywhere because from there it can get pretty bad. It can get septic on the whole body. And prognosis in this case, it could be like sometimes fair to good. Another thing that can happen also is tendon shear wounds, which is pretty close also to the septic area, so be aware of that. Sorry, coming back a little bit on the solar abscess, I forgot to tell you, if we end in discovering that the patient has an abscess for sure, the treatment of choice for abscess is going to be poulticing the feet. So we're going to pick up the feet, we're going to clean the feet pretty well, we're going to look around, and we're going to start doing our checkup as usual. We're going to check with our hoof testers and be sure that there's nothing showing us the possibility of reaction. If it is, then we're going to find the pocket, and if we find the pocket, then we can start working with poulticing the feet. There's different type of ways to do this. Some people, they use baby diapers. Some people, they use the base of those 4 gallons containers. And some people, you use a little bit of Ictamol before to clean it up, just to start poulticing. Some people, they use another type of cataplasm that they already sold in the market, ready to poultice in. So there's many in the market. Wrap it around. Just wait for that one to mature. Usually take 3-4 days. Remove it, clean it up again. You need more time, put another one. And non-steroidals, anti-inflammatories for pain. And once the abscess start draining, the horse is going to get much better and better and better. But we have to help them to start maturing a little bit. So keep that one in mind. It's not an easy wrap to do, so you always have to secure it pretty well. You're gonna have to use one of those plastic tape or aluminum tape that is pretty good strain. So that's something that you have to keep in mind when you're working with these horses. All right, thank you very much. We're gonna be seeing you at the next topic in a few seconds. All right, so the next topic that we're seeing today is gastrointestinal parasites. So gastrointestinal parasites, basically, we can divide it in different organisms. And I'm talking about gastrointestinal parasites, for example, like cytostomes, which is usually called a small strongyle. Usually those guys are pretty bad for the large intestine. They damage the large intestine. And one of the consequences of damaging the large intestine, right, it'll be causing what is called protein loss enteropathy. So we're going to be less proteinemic just because of the fact that we have these parasites over there invading. The second one that we're going to be talking is about Strongylus vulgaris. Strongylus vulgaris is considered as a large strongyle, okay? And with this guy, we have to be extra careful because there's a migration process with this worm. The migration process, it goes in between the mesenteric artery, and I can have large intestine infarction. So actually, I can have a bleeding out of this because the worm migrating from one area to another area, and then definitely causing big damage inside the abdominal organs. So it is a pretty tough one. The third one that we have that is pretty classic too is going to be tapeworm. And tapeworm is another one that we're going to find causing a lot of colics too. So remember, tapeworm with colic goes with the ham, and usually it causes a lot of damage on the ileocecal junction. The ileocecal junction. Remember, we have duodenum, we have jejunum, we have ileum, right? Once they come out of the stomach. And then once that we get right there at the junction, where we're meeting the cecum, right, which is the area where the patient is going to be fermented, that's a preferred damage for this type of parasite. Or preferred area to be hanging right there and causing damage on the surface. And then the fourth one is going to be roundworms. Pretty known to be happening on colts, right? Younger patients. Same thing with dogs. You know, when you are younger dogs, the mature immune system is not fully mature. We're going to still having issues with parasites. So colts is one of those. With colts that they have like this type of impactation, we can have full impactation after deworming. So we have to be pretty careful about what kind of dewormer are we using, because it's being reported that from this type of ascarids, right, which is a roundworm ascarids, it's the same. It could be obstruction if we're using the paralytic dewormer, what is called Parentel. The problem with Parentel is the paralytic dewormer, and the problem with the paralytic dewormer is like on these paralytic dewormers, once they get paralyzed, the gastrointestinal tract continue moving, and then they become like a whole bunch of them. And since they're paralyzed, the problem with this is that they can cause obstruction, impaction, and even rupture of the internal structure of the intestine. So we have to be pretty careful with that one. In some cases, when we're considering heavy parasitosis, or in these cases, we recommend to do better either another type of dewormers. For example, febendazole. It's pretty good. We can use it for a small strongyle for the cytostomes. And we have ivermectin, which is great to use for the larger Strongylus vulgaris. For example, roundworms. On these cases, we recommend to use Panicure, because, as I said before, with Parentel, if the amount of worms is pretty high, we can have paralytic impaction. Panicure is not a paralytic, so it will kill. It's still moving out, but no paralyzing. And then bunching it up together. And then finally, for tapeworms, what we talked before, they like to hang out with the ileocecal bulb. We have praziquantel. So be aware of that. So yeah, so fall impaction is one of the main things. Always keep it in mind when we're talking about this. Most of the cases, we still recommend to do your fecal egg count. So if you feel like you can do your fecal, for tapeworms, we can start doing tapeworm titers in serum if you like. But consider that differential diagnostics, it will be a colitis, weight loss. But basically, parasite is something that is pretty common. What we're recommending is not to do it that often. Look at the hair of the goat, the horse. Be sure it's looking in shade. Be sure it's not looking, body score is poor. It looks pretty hydrated. He doesn't look anemic. Overall, good physical exam and a fecal exam. And then based on that, start the warmer. Look at the season of the year. Some worms are more popular before winter, like summer. But if you're going to go to the winter season, maybe you don't need that much dewormers. So try to minimize that, because the problem with dewormers is like overuse of them, and that's happening lately too much, and then we have so much parasite resistance. All right, keep it in mind. We'll see you in the next talk. All right, so now we're right here with viral respiratory. And as we can see here on viral respiratory, we have a history of fever, because of course it's a virus, so viruses are going to create fever. And second of all, we're going to have a little bit of respiratory distress. So we're dealing with a lot of cough, right? That's the main thing we're going to be seeing. Some cases, they might have a nasal discharge, of course, most of the time bilateral. And also we have enlargements of the lymph nodes. Remember, other of the causes that we have enlargement of the lymph nodes, exaggerated, it will be strangles, as we talked before, usually seen on younger horses. But it can happen also as well with viral respiratory. So keep it that one in mind. So one of the main things that we can consider for differential diagnostics on viral respiratory, besides the fact that we have coughing, enlargement of the lymph node, maybe fever, maybe crackles, increasing of respiratory effort and rate, it's going to be a differential diagnostics. We can think about influenza. We can think about herpes virus. We can think about equine recurrent uveitis, rhinitis, airway disease. But basically, when we're seeing isolation, when we're seeing young horses with this type of respiratory, we recommend to do isolation. So herpes virus is one of those. Herpes virus, it is basically one of the ones that cause abortion, and pretty much seen in young horses, pretty contagious, seen in the third trimester and abortions. Good prognosis with herpes virus if we treat quickly, beside the fact of abortion. But keep it in mind that that's something that can happen with the viral respiratory diseases. So the main one, it will be herpes virus, young horses, mostly mingle at the shows. It's kind of like the same thing with strangles, mingle at the show. But the problem, it will be third trimester abortions on mare. And most of the time, it's only just a respiratory. They come out of this unless there's an exaggerated complication with pneumonia or something else. All right, we're back to the track. So next one is going to be horses and the estrus cycle. So basically on horses, we're going to be understanding that there are seasonal polyestrus. Typically, season goes anywhere between April to October. Cycle usually is about 21 days. And I would say, like most of the time, I would say you see the highest number April, May, June, a little bit of July. And then it starts declining, depending on which area you're at. But mostly on the southern hemisphere or southern United States is mostly at that time of the year. So keep in mind a couple of considerations for the horse. Basically, during estrus, estrogen is going to go up. It's going to start raising up on the horse, and usually 5 to 7 days. And after this time, when the estrus goes up and estrogen goes up during this estrus, the ovulation is going to happen 1 to 2 days prior to the end of estrus. So that's pretty much when ovulation is going to happen. So, as we said before, we're going to be considering also for mares that they have a pretty long gestation, 345 days in a year, which is a lot. 9 to 10 days after falling, they can get on heat. So they have a condition that's called fall heat. So they just, have partition like 9 or 10 days ago, and they're ready to be like mounted again. And probably because, their anatomy and their physiology to have like only one spring once yearly. So pretty much. There's techniques that they can do it during the winter in order to encourage this seasonal polyestrus to getting heat and mostly increasing light. In this case, it will be like artificial light. We're talking about like 16 hours daylight. And it can happen, with a good nutrition, and we can breed in over there. So there's a chance that we can do that even in winter. Not commonly used, but it's always that can happen. So anytime that you're gonna be breeding the horse on this period that we talked before, 5 to 7 days is gonna be the estrus cycle, and then ovulation is gonna happen 1 or 2 days prior to the ending. So by the day 5th day, pretty much, we're gonna be breeding every other day until the fall is out of heat, or 24 to 40 hours prior to ovulation. So we have to keep that one in mind. Prior to ovulation. If we end up using synchronization, we can also consider the use of prostaglandin F2 alpha, something that we can use in horses. The problem with horses is like they don't take it that well like a horse, a large animal, like a ruminant. Typically, we can see a little bit of side effects with prostaglandin after injection, typically 16 minutes after it's given. We can have diarrhea, we can have a little bit of colic, we can have muscle cramps, we can have elevated heart rate, a little bit of tachycardia. So all these things kind of like one of those downsides of it. But if we end up doing it, we're going to expect after this injection of the prostaglandin 8 to 9 days for ovulation, and then we can certainly start doing our artificial insemination by then. So we can use artificial insemination to synchronize and prevent this long diestrus. And other option that we can use besides the prostaglandin will be the administration of progestin PO, and 12 to 14 days after this, then we can ingest prostaglandin again. But I think typically people, they just use straight out the prostaglandin, even if they have the chance of the side effects. And then after a few days later, 8 to 9 days, just wait for the ovulation and start doing their insemination. All right. So most of the time they use follicular measurement, and that's a pretty common practice to find out if we're ready for breeding. Thank you. All right. Time to talk a little more about the heart. Atrial fibrillation. So atrial fibrillation, it is mostly known for athletic horses. Patients that they start showing a little bit of exercise intolerance, that's something that should be giving us a main clue for this. The other thing, it will be an incidental finding until any physical exam, or if we start seeing a little bit of poor performance with the horse. So remember, there's a blockage in the horse, which is a second degree AB block, okay? And second degree AB block, it is considered non-pathological in the horse, even if it is a block. Sometimes we can see heart anywhere between the 25 to the 40s with the second degree AB block, but otherwise the horse is normal with no problem. So that's pretty much something that just keep it in mind. So with atrial fibrillation, the real atrial fibrillation, we're gonna have a weird rhythm, right? We're gonna have an irregular heartbeat. So it's not like a pop pop. It is like boom 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 boom. So we have like irregular heartbeat. Typically, we're gonna have pretty much a normal QRS complex, and then we're gonna have a P, and then we're gonna have another P, and then another P, and then we have a QRS complex. So basically, we're missing our QRSs. The atrium is still firing, still fibrillating, but nothing else is happening. So something to keep it in mind. Horses, they can have a high vagal tone, like a cat's, right? And also they can have atrial dilation, and some of the electrolyte disturbances can be like related with this as well. But as we said before, it's seen mostly on athletic horses. And if we end up finding this and we have this R2R irregular fibrillator wave, and we know that it's true, we already did our diagnostics, and nothing else to rule it out, then we can start our treatment for conversion. The mainstay of treatment, gold standard, it will be transvenous electrical cardioversion. That's the newer one. And that has to be a referral facility for sure. Now, if you want to do just medical treatment, you can try to convert with quinidine, but the problem with quinidine is always side effects. Diarrhea, colic, laminitis, bad side effects. So those side effects can happen, and if those side effects are happening, you have to really think about it before to use it, but it is a possibility if referral is not one of those things that you end in considering. So that'll be for atrial fibrillation. Just remember, second degree AV block on the horse is non-pathological, and atrial fibrillation it is. Now we're ready to talk about the treatments. All right, now we're going to be talking a little bit about eyes. Basically, the main condition we have with eyes, it'll be equine recurrent uveitis. Pretty much a known condition on Appaloosa's. It's kind of like the predilected breed for this. Also, it's been related to leptospira infection. Remember, if we're seeing something that is chronic, like equine recurrent uveitis, always keep in mind the leptospira could be a fact in it. So basically, the stain is going to be negative, and of course, because nothing is going on the outer part of the eye, but we're still doing our stain just to be sure that there's no any concurrent ulcers. And what we're seeing basically, it's a pretty bad inflammation of the uveal tract. And we're talking about uveal tract, we're talking about inside the eyeball. We're going to be seeing this one in the anterior chamber. The problem with this type of condition is it's a chronic condition, and being a chronic condition, it can give you changes that they can lead to chronic diseases. And those cases, one of the concerns that we have will be cataracts. Another thing that we can consider also will be chronic retinal scarring, because that's another thing that can happen. Scarring is another thing. And intraocular adhesions. In some cases, when it's all chronic and pressure has been compromised, we can even have a regression of the eye, which will be shrinking of the eye, which is a fasciitis bulbi. Typically, to control the inflammation, just rule it out. First of all, be sure not dealing with the leptospira. And if it is not the case, then we can give in steroidals, topicals, anti-inflammatories, and hoping for the best. Prednisone, dexamethasone, first line on defense for equine recurrent uveitis. Keep us updated. All right, now we're talking about eyes. We have corneal ulcers. So corneal ulcers can happen with the horse because, they're nature to be around things. They like to be in between brush, like to be around trees, and sometimes things can happen. So first complaint, blepharospasm. Second complaint, photophobia. Third complaint, ocular discharge. Pretty classic presentation. Pretty much, squinting the eye a little bit of discharge, a little bit phobic with the light, so which is completely understandable. So in order to do a little bit of diagnostic with these guys, everything depends on comfort level. If it's really painful and the horse is not letting you take a look within the eyeball, that could be an issue. In some cases, we have to do a little bit of diagnostics, and if it is the case, we're gonna have to be using a little bit of local anesthesia. Sorry. So we're gonna using nerve blocks, basically the auricular palpebral nerve block, which is gonna help us to control the motion CNM5. And the cranial nerve 5 is going to be controlled, and we're going to be able to open more the eye. And then we're going to be able to do our stain and be sure that there's no defect. Typically, we see the cornea is being ulcerated maybe for more than 24 hours. We're going to start seeing vessels. Vessels usually grow like 0.05 millimeters per day. So that's something that we can start noticing in there. We can also use for Bengal stain. Of course, the patient is going to have a little bit of epiphora. The eye is going to be myotic, so be aware of that. And we don't want to wait too long, really, to start doing an assessment on this, because certainly those ulcers, they can get complicated quickly. So we need to start intervening, and we need to be pretty proactive and start hitting it hard, because you don't know what's kind of fungal or bacterial agent, and you don't want this to become like a melting ulcer, and that's going to be a trouble for sure. So, differential diagnostic for this type of conditions, as we talked before, it could be a stromal abscess, equine recurrent uveitis, viral keratitis. So the main ones on horses. So always keep it in mind. And I would say like a good number of cases, they always have pseudomonas. Pseudomonas, Streptococcus, beta hemolytics, and fungi. Those three are the main involved on this corneal ulcer on horses. So if we have a bacterial case, what we recommend typically is broad spectrum antibiotics for the eye, topical. We can do ofloxacin. If we have a little bit of miosis, as we talked before, we can add some atropine in there. And of course, we can also give in comfort level with a little bit of flunexin, IV, Banamine. And we can also do autologous serum. Great. We can just pull some blood, horse is healthy, pull it out, and start using it. Centrifuge it, separate it, keep it in the fridge, no longer than 7 days, and then discard. So basically, don't wait too long, because as we said before, pseudomonas can go easy, start melting the eye, and they can get like worse. Suprapalpebral lavage is something that sometimes is recommended in horses for continued treatments if it's reluctant to do the treatment, so that's a possibility as well. But everything depending on comfort and the horse, if it's cooperating or not. But never ever use steroids, because certainly if we do steroids, we're going to stop the healing, and then as a consequence of stopping the healing process is going to be more infection, and then we can certainly lose a whole eye. All right, thank you. All right, we're back, and now we're going to start working with sinusitis. So sinusitis is basically a condition that we're going to be seeing a lot in horses. We can have mostly of the time, I would say like 99% of the time, unilateral discharge. So pretty pathognomonic of horses, lateral discharge, only one side. If we end up having bilateral discharge, we can start considering other things like good old pouch emphysema, which, you know, they're all the way on the top, and also pneumonia, right, or any viral disease as well. So basically, I would say like most of the time, sinusitis is always secondary, not really a specific. And tooth-related is a big theme. Sinus neoplasia, ethmoid hematoma, dental issues, that's basically where we can see a secondary. Now, if we had as a primary, it has to be, most of the time, a sequela of a viral disease. So upper respiratory viral disease, sequela, that's going to be a sinusitis if we're not considering something else, as we talked before. For example, we have endocrine disease like a PPID. It's a pre-existing cause of sinusitis, so keep it in mind, be aware of that. Pituitary parts intermediate dysfunction is something that is pre-existing, cause of sinusitis. Infected tube, hundreds and 200 arcades, which are usually the upper ones, right and left, versus a mass, could be a cause of sinusitis. Most of the time, treatment they're going to be focused on preventing infection because the irritation of the sinuses. We can do antibiotics. We also consider, in worst cases, either a sinus lavage with needle and saline. That's a possibility as well. A little more like in-depth treatment, but something else keep in mind as possible. Thank you. All right, it's time to talk about those horses that they're always working pretty hard. Rhabdomyolysis, it is used to be called also tying up or Monday's working disease, right? Horse pretty much working the whole week, having a day off on Saturday, and then getting all tired by Monday with this myopathy. So tying up, basically, we're going to see a horse that is dehydrated. You're going to see a horse that is going to be pretty tired, not wanting to move and everything after doing a pretty bad exertion exercise that is causing necrosis on his muscles. We can see cases where we can have a little bit of myoglobinuria. And we're still doing our blood work. You're going to be seeing basically muscle damage. We can have a few enzymes on the horse that we can evaluate for muscle damage. One of those will be CK. We also have AST and creatinine. But I think the most important one out of these three ones is going to be AST. AST usually, it will give us the indication that there's also a kidney involvement. And consideration with this one, it will be the poor filtration because of the myoglobinuria. Just consider the myocytes being a larger protein to be filtrated, so it's not that easy to be filtrated. So keep that one in mind. Besides the myoglobinuria, which is bad for the kidneys, we can also have casts in urine, urinary casts. So always take a look for renal damage. Check your creatinine, as we said before, with this type of condition. Usually seen on larger horses, and mostly horses that are doing like a continuous exercising 7 days a week, working in different activities. So could be pretty known. There's another condition that is called PSSM, and usually seen in a genetic condition on the draft horse. There's another type of myositis, the polysaccharide myositis, and mortality could be pretty high, up to 75%. So also keep an eye with box elder, which is another type of toxin, which you can have also pasture myositis. And also another consideration to keep in mind when we're seeing this rhabdomyolysis, it will be white muscle disease, where CK is going to be high, same thing on the rhabdomyolysis. AST is going to be high, same thing the rhabdomyolysis, but selenium and vitamin E is going to be on the floor. It's going to be low. So that's the big difference between white muscle disease and really rhabdomyolysis. I guess that's pretty much for now. Thank you. Okay, we're back here, and now we're going to start talking a little bit about PPID, or pituitary parts intermediate disease, basically Cushing's. So here we have a little bit of endocrine disease going on. We're basically working with hyperplasia of the pituitary gland. So the hypothalamus basically is going to be creating inhibitors that they're not going to let this pituitary parts intermedia to generate what is the dopamine in there. So the consequence of that, it'll be pretty much the lack of dopamine on his whole body. And then we can have all these extra signs that we're seeing on his body. So hypothalamus, over dopamine, inhibits the pituitary parts intermedia, and no dopamine grows in the body. So everything comes from the hypothalamus. Okay, so inhibits the pituitary pars intermedia and no dopamine. Frequent signs we're going to be seeing polyuria and polyphagia, right? The horse is going to be eating more, horse is going to be drinking more, polydipsia, and one pathognomonic sign is going to be the hirsutism, which is basically extra hair, excessively growing hair, which is not adequate to the season, it's not adequate to the breed. We can see fat deposits all over the body. We can see muscle weights. Some cases they have hyperglycemia. Some cases they could be hyperinsulinemic, and even the liver enzymes could be up. The hyperglycemia comes because remember, insulin is a vasoactive compound, and it can cause also laminitis as well because insulin is vasoactive. So remember that can increase also the chance to have laminitis. So as we said before, the test for this type of testing is going to be ACTH. We're going to be testing endogenous ACTH, and that will be our main test. Secondary test that we can do is thyroid releasing hormone, and then ACTH on top of that, and that will be a provocative test. So we can do the initial one with thyroid releasing hormone, and then 30 minutes later check the ACTH injecting. Of course, come out positive, then we have the diagnosis. And the third test will be a dexamethasone suppression test. But at this point, I think the most important one that everybody does is ACTH endogenous. So treatment of choice, pergolide, which is basically synthetic dopamine. That's what we're providing to the patient. Some cases they also have tried cyproheptadine, which is a serotonin antagonist, cyproheptadine. So that's another one that you can use for that too as well. All right, so just keep an eye on those older horses and be sure that we're not skipping one of those diseases, mostly when we're seeing chronic laminitis. Talking a little bit about infectious causes versus non-infectious causes of abortion and the mare. Infectious causes, always keep in mind the viruses. Herpes virus 1, as we talked before, third trimester. We can also keep in mind EVA, which is equine viral arteritis. We can keep in mind Leptospira as a bacteria. We can keep a bacteria Nocardia. We can keep a bacteria Streptococci. We can strangles, right? We can keep a bacteria Pseudomonas, and even fungal when we can have cases like a placentitis. Non-infectious, basically we're seeing a fascious toxicity or maybe umbilical torsion. That's a possibility as well. So herpes virus, if we ain't having it, we need to isolate. Remember, it's pretty bad disease, pretty transmissible, so we don't want all the farm to get infected with herpes virus. And yes, unfortunately, we have these different stages where we can have abortion. The best way to go is fetal necropsy, and based on that, tissue sampling, cultures, and try to determine what is the instigating pathogen. All right, next on the list is going to be skin tumors, and today we're going to be talking about three main ones. One of those is going to be sarcoid, the second one is going to be squamous cell carcinoma, and the third one is going to be melanoma. So skin tumors, basically, talking about sarcoids is something that we can find in different areas of the body, pretty much related with flies. We can have sarcoids on the ears, ear pinnies. We can have occult, and we can have verrucous. We can have malignant. So there's a different type of mix of sarcoids. So we have to keep an eye on that and be sure that there's not like a big population of those going on. So as I said before, the most common sarcoids, usually the most popular. Treatment is usually excision and then cryotherapy on those cases. Regarding what it is, squamous cell carcinoma, which will be the second one. Squamous cell carcinoma, basically we're going to see it more on the genitalia area on the horse. We can see it on the penis. We can see it on the sheath. We can see it on the perineal area by the female. So just something that we can check also on the vulva. So we say male before, squamous cell carcinoma, we can do a biopsy. Is there chronic irritation? Is there a smegma in there? On the female, squamous cell carcinoma on the perineal area, mostly on white horses, usually because of poor pigmentation, as we talked before, and it's squamous cell carcinoma. Same thing on the cat, right? When they have like a white cats and then they start like having issues with their ear pinna and start getting tumors as well. So white horse disease, mostly for Appaloosas or draft horses, it's pretty much in a typical metastasis. So no, not really chance for metastatic disease. So it's mostly pretty atypical if it happens, but it's pretty localized and it could be painful. And the other thing that we have here is going to be melanoma. And basically with melanoma, we're going to relate that one to a gray horse. And melanoma, basically we're going to look at the perineal area, we're going to look at the lips, and usually happen in horses that are over 10 years old. So I think that's a pretty good key factor to keep in mind. And as we said before, we do our rundown all the umbilicals and all the way to the sheath and find out that there's no like possible melanomas in the prepuce on males. On a female, once again, we look about the vulva. And mostly gray horses, be sure that there's no like any lips involvement or perineal involvement, usually more than 10 years before. I think that most of the time for melanomas, what we do with these guys, as long as they're controlled and they're not like causing any pain or discharge or major irritation, it'll be basically benign neglected. So pretty much forgetting about them and see, the horse can live with that. But as I said before, if it gets static, they can live with that with no problems. If it's not getting static and getting larger, then more investigation might need to be pursued. All right, thank you. All right, next disease we're going to be doing is equine infectious anemia. Pretty classic. We remember we had to do the testing for equine infectious anemia. That's one of those things that we had to do in our profession. Typically costs about like $60 average everywhere. What do we need for that? Well, first of all, we need to talk to the owner. We need to get a little bit of history. We need to do the identification of the patient. So we're going to be looking at the patient and describing what are we seeing. Remember, we have to look everything, any tattoos, any branding, any words, any situations regarding with the colors and markings. So pretty important. We're seeing like legs, for example. We're going to do a checking in coordinates. We're going to check in posture. We're going to check socks. We're going to check stockinette. If we're going to be like checking for warts, we can check warts all around their body and see if there's saddle marks. Branding, as we said before, and then the face. The face is pretty important. We're checking to be sure that there's no like any kind of like pigments. We're seeing the muscle. We're looking for a snip. We're looking for a blaze. We're looking for a star. We're looking for a strip. So be aware of those things. And of course, certainly the color of the horse. And then we're going to collect our sample, get a little bit of alcohol, clean his neck, get a jugular sample. Typically, we just need 1 ml of serum to send it out. Typically, serology. So you can pull it out, and a couple cc's of blood will be more than enough. And just save it on red top or tiger top serum separator. Just do the serology. So there's a couple ways to do this. We can do ELISA and we can do AGID test. ELISA is faster. Results are pretty quick. AGID 2 takes a little longer, but prices are around the same. So just keep it in mind. So positive identification, collection of the sample, send it out, and pretty much required by law, required by interstate when we're moving one horse to another state, just to be sure everything is fine. So going back to equine infectious anemia, equine infectious anemia is a lentis virus. It's a lifelong virus. So once I had it, it's going to be pretty much contagious forever. So that's the downside of this disease. You don't have to actually euthanize the dog, but you can pursue the owner to euthanize it. But unfortunately, as we said before, since it's a pretty high transmissible disease, the regulations are pretty tough. So this horse is going to have to be like miles radius around the area where he's at by itself forever, pretty much for life. So keep it in mind. Check the gums. Be sure when you're seeing any petechias. In some cases, they could be a little bit inappetent if it's acute presentation, chronic presentation, less inappetent. But as I said before, 200 yards all the way around to be quarantined. So, differential diagnostic for this type of diseases, we're seeing febrile illness and purpura hemorrhagica. As we said before, we had the serology, everything having the last name of Leroy Coggins, doctor back in the 70s who started working hard on this to achieve this type of testing and try to prevent this viral disease to be spread out. Keep an eye on the insects, blood, insect bites, because that could be a main thing for transmission. So always keep that one in mind in case that you want to have a good barn. You're going to have a good system to control all the mosquitoes, because you don't want any vector-borne start like bring all these things around your farm. Thank you. All right. We're back here, and the next one, disease that we're covering today is encephalomyelitis, basically transmitted by mosquitoes, right, or arboviral disease. It's another way to call a mosquito. So basically on encephalomyelitis, we have to consider three main diseases. The first one, which is going to be that it's transmitted by mosquito, is the West Nile virus, which is one of the arbovirus diseases that we're more concerned in all North America. The second one is going to be the equine eastern myeloencephalitis. And then the third one is going to be the Western equine encephalitis. So with mosquito vector-borne, all of them born mosquito, but the West Nile virus, basically we start seeing a little more of fever, and we can have muscle fasciculations on the neck, which could be a situation. So that's something to keep in mind. And with the Eastern, it seems to be a little more aggressive. The Western typically seen on the Eastern states. Florida, for example, is one of those. We can see a lot of head pressing. We can see seizures. And with the Western, we can see a little more being a little less pathogenic than the other two. Because certainly it's something that it is on the list, but it's seen usually rarely, like 20 or 40% of the cases, and usually located on the west, which is very much like California states. This is pretty much a disease which is going to show neurological signs. So central nervous system, we're going to have ataxia, we're going to have a little bit of paresis. So keep that one in mind. You need to handle all these type of diseases as rabies, because as we said before, rabies could be as a good differential diagnosis for any encephalopathy. So always keep it like that. Keep it in your diagnostics, because it's pretty important. So as we said before, differential diagnosis, we're seeing rabies. We're also seeing EPM, which is equine perso and myeloencephalopathy, and that's usually caused by the opossum. And then EHB1, which is equine herpes virus 1 as well. So keep it in mind, very important. So we have testing, basically cerebrospinal fluid, ELISA for West Nile, that's something that is available. If we end up having a real case of EPM, we can use tetracyclines, neoborrelia, that one's help us with that one as well. Basically for encephalitis, we have a treatment support, basically just support care, and control the vectors, the mosquitoes, and the most importantly, vaccinate the dogs, the horses. We always have to vaccinate these guys just to be sure that there's not going to be any exposure to these things, and if it is, they're going to be protected. So something to keep in mind on your core vaccines for sure. This is a important one. There's a market vaccine which carries all these three. Venezuelan encephalitis, Japanese encephalitis, those are other things that you can see on the market as well, but not really commonly seen here in North America. Venezuelan, we've seen a few cases. but it's not really considered as a core vaccine. But pretty aggressive too. And Japanese, it will be just considered exotics, really, to be honest. But I think just because of the awareness and the vaccination, people are seeing less cases of those. But if you start seeing any Eastern or Venezuelan, always think about zoonosis, because this could be certainly transmissible to people, and they can cause pretty high viremia. So be careful with those two. All right, thank you. All right, it's time to talk a little bit about equine hepatobiliary disorders. Basically, talking about livers today. So one of the main things that we're going to see with these guys, it is head pressing and icterus. They're going to be icterus all over. It could be the gums, it could be the scleral eyes, it could be around the perineal area. So those are worst cases for sure. But central icteria is something that we can see a lot. Head pressing because, liver, and causing a little bit of CNS involvement because of the possible ammonia levels going up. So we do a little bit of blood work in horses. GGT, basically we're going to have elevated biliary and periportal. And SDH is going to show us acute hepatic injury, right? It's kind of like a total bilirubin in the dog, but this is the version of the horse. And then ALP, which is going to be bone related, and then AST on the muscle. So liver biopsy will be a preferred thing, but it's something that sometimes is not available everywhere. Not everybody can do it as well. Within these two diseases, within these particular diseases, there's a couple of diseases that are the main ones. And the first one I'm going to say is Tyler's disease, which is acute hepatitis. Usually you can see a lot of lethargy, icterus, hepatoencephalopathy. Basically, the way to go with this one is just to recur. It's a poor prognosis disease on Taylor's disease. So might euthanize the horse, the possibility. So depending on how bad it's affecting the liver and CNS. Hepatic lipidosis is a fat liver. And basically on hepatic lipidosis, it's pretty known to be happening on donkeys, miniature ponies. You see a lot of obesity, you see a lot of ketones. Triglycerides are going to be pretty high, typically over 500. It's going to be lethargy, it's going to be anorexia and weakness. And what you have to do is basically correct the primary problem. And in order to correct the primary problem, what you have to do is nasogastric tube. I'm going to do a little bit of parental nutrition, PPN, TPM, just to correct that one and keep the liver running. And if the patient is reacting, well, it's going to get better, hoping that, of course, there's no secondary complications. Thank you. All right, ready to go. We're on the next one, and we are looking at equine metabolic syndrome. So basically, on this disease, we can see younger horses, or could be older horses. Basically, what we're going to see is a lot of fat. Fat horse that is going to bring to laminitis. You can see fat on the nuclear ligament, right? Behind the neck, you can see fat on the abdominal area, lower abdomen. You can see fat by the gluteal area as well. So just keep someone in mind for older patients. Equine metabolic syndrome, this fat horse, it can eventually lead to be a PPID horse. So that's something that always have to keep in mind when you are looking at these horses. So for younger horses and older horses, we're going to start doing a little bit of testing. Usually fasting insulin test is important, and also glucose challenge test as well. Another thing that we can also be checking is the genetic of these patients. Some of these patients, they can have some related with genetics. For example, the Morgans, the ponies, the donkeys, those are the one. Another thing that we can see on these fat horses, just because they're fat predisposition, is going to be they're going to be showing insidious laminitis. She could be subclinical, but remember, insulin resistant, insulinemia, insulin Insulin is a vasoactive compound. That's the problem. Leads to laminitis. Always think like that. Insulin, vasodilation, laminitis. Basically, it's just a chain that goes all together. So, treatment, basically start doing a little more exercise, less feeding on carbohydrates. We're going to start also thyroxine, start helping with his metabolism to start speeding up a little bit and get rid of the fat. And we have like resisting insulinemia, then we can start using metformin on those cases. But yeah, but basically management and keeping an eye on internal caloric and be sure it's not worsening and converting to be a PPID at some point. Thank you. All right, next one that we have here today is equine good old pouch. So this is pretty much a disease. It can happen on the good old pouch of horses. There's different type of versions of this disease, so we're gonna go over those. So the first one is gonna be a tympany. So we can have a tympany actually in the good old pouch. Usually happen on younger horses. It's kind of like the air gets trapped in there. It could be like unilateral on the good old pouch. It could be bilateral on the good old pouch. Typically, it's not painful, but it's more like a pressure disease than anything else. Just having the good old pouch filled with air. So it's kind of like a cosmetic thing. It's just kind of unknown why there is trapped in there, but it's certainly affecting this area. As we know, the good old pouch is the diverticulum of the Eustachian tubes. So for some reason, on this good old pouch, which has a capacity of 300 to 500 milliliters, a capacity to save either air or fluid, ending getting trapped in there. So that's a situation. In some cases, when there's so much inflammation in the area, we can have a little bit of nerve involvement. We have the cranial nerve number 8, number 9, 10, 11, and 12 going all the way over there, and we can have associated disease that is causing damage just because of the ground pouch starts showing things. So pretty important to keep in mind if we start seeing any neurological signs too as well. So we're gonna be also talking about fenestration, which is a hole that we can do in there in order to relieve the tympany. So that's something to keep in mind. The other thing that we can tell about good old pouch is gonna be good old pouch emphysema. So emphysema is usually just an exudate on the good old pouch. Usually, streptococcus is one of the causative agents in it. So you're going to see a lymphadenopathy, same thing that we've seen on strangles, as we said before, dysphagia. But the interesting part of this streptococcus, since it's so chronic, is going to be the presence of chondroids, which are a little bit like a hard version of the exudate. Pretty much is the exudate become desiccated. It's all like dry pieces of exudate. It could be the size of a coin, a little larger than a coin, maybe 2 quarter coins together, maybe 4 coins together, and many of those. So certainly in those cases, what we recommend to do is a little bit of treatment to do in good old pouch lavage, antimicrobial, in some cases even surgery to try to remove these guys out of there. The third case of good old pouch that we can be talking today is going to be fungal flakes. So be aware of that. It can happen with the fungal agent. And we can see on these cases, most of the time, epitaxis. That's one of the main things on horses. You see epitaxis, you can start thinking about like equine pulmonary hemorrhage exercise induced, which can happen, but mostly they're healthy horses that they're in the right strike, right? But that's a cause of that. You can think about any thrombocytopenia. You can think about like any other disease on the liver that could be affecting the coagulation factors. But in this case, since it's coming from the good old pouch, it's going to bring a little bit of fluid with blood in there. Dysphagia, it's another thing. And certainly we can identify this by endoscopy. We're going to lose like these patches over there. And really based on fungal plaques. Strongo is a retropharyngeal lymph node, as we talked before. It can cause fever. We need to isolate bacterial culture Antibiotics, non-steroidals, as we said before, isolation, isolation, isolation. But on equine good old pouches, we have to be sure what we're dealing. So be sure that we have those four, basically, bacterial causes, fungal causes, tympany, or complicated strangle, which will be the version of emphysema. Thank you. All right, it's time to talk about colitis today. So the first thing what we need to know about colitis is zoonotic. Salmonella and Clostridium is the main thing. So always keep it in mind, mostly for whoever is working with you, whoever is in your farm, whoever people is around you, because you don't want this to get like out of control. And mostly if it's like a zoonosis. So keep that one in mind. Depression, anorexia, hypermotility, it could be contagious, isolation. That's something that you have to keep in mind anytime that you're seeing any diarrheas. So we have different type of diarrheas as we know before. We talk about like viral diarrheas. We talk about like clostridial diarrheas. So keep all these things in mind. Fall diarrheas usually happen anywhere between 10 to 12 years old, and it could be up to normal in some cases. But when we start seeing blood in there, we start concerned about that. Clinical signs besides depression, anorexia, and hypermotility, as we talked before. Pitolism, if there's any kind of gastrointestinal ulcers, patient could be highly dehydrated, patient could be shocky as well. So in some cases, if we're dealing pretty much either a viral or a bacterial agent, we can start using our testings. We have a PCR. We can have also for virals, we have a PCR, sorry. For parasitic, we have egg count. For toxics, for example, we can consider a Kettering toxicity. That's something that you can also look into if you have a chronic diarrhea. Erythromycins in an adult horse, it will be killing it. So we always give it to the younger horse, right? Anywhere between 2 to 6 months old, along with rifampin, in case that we had the pulmonary abscessation, as we talked before. So keep that one in mind. Clostridium perfringens. Basically, it's one of causative of diarrhea, difficile A, salmonella, neurorickettsia, those can cause diarrhea. Viral causes, we can think about corona, we can talk about like rotavirus, so those are the one, and causing hemorrhagic diarrhea, fever. Another one could be Lawsonia intracellularis, 4 to 6 months of age. Causing a thick intestines, and then as a consequence of that, we'll have the PLE or protein loss enteropathy, which we're not saving those proteins in our system because the thick intestine is not able to absorb because of that, right? So typically it's a gram-negative bacteria, and ultrasound will help us to diagnose depending on the thickness of the intestine, and then we can use our tetracycline medication antibiotic, and then support basically with IV fluids. We can also use colloid fluids in order to support this losing enteropathy. If we're considering a toxic cause, we're talking about blister beetle, which is one of those. And the other one also, keep it in mind, because you start using a lot of this, is a non-steroidal inflammatory, which it can happen to. Remember, right dorsal colitis, it could be caused by non-steroidal anti-inflammatory. So remember, when you're doing your physical exam on the horse, you're positioning the horse on the right side and the left side, right? Looking on the right side, if you're looking at the horse, you're going to have on the lower and upper quadrant of the abdomen the cecum, which is going to take a good part of it. But if you go a little further up cranially, you're going to find your column, right? And then that's when you're going to find that you can have a right dorsal colitis over there. Sciastomasis is another one that is a possible cause, so that one keep it in mind as well. But as we talked before, diarrhea is the thing. As we talked before, with Clostridium, typically we use metronidazole. If we have any Clostridial diarrhea, metronidazole is the way to go. For Potomac horse fever, which is caused by the neurorickettsia, the PHF, Potomac horse fever, right? Potomac because the Potomac River, that's right there up in Washington. Neurorickettsia usually transmitted by vector, you're gonna use oxytetracycline. Remember that. In some cases, when we have laminitis because of this, the patient can be neutropenic. You need to give antibiotics, as we said before. Okay, oxytetracycline is the preferred one. So keep an eye on that. Basically, keep an eye on your testing and the hydration status on the patient, and choose the appropriate treatment for it. All right, thank you. All right, another thing that I think is pretty important to talk today is about sepsis in fall. So sepsis is a big thing in falls, really. I mean, you can send a fall easy to the ICU unit. If you don't do a good management and you're coming too late, they go quick. It's like a baby. It gets sick. It can go quick and sick. So typically it's happening in a fall that they just have a few hours of life, even days. You say like 1 day, 2 days. Suddenly start looking lethargic. Suddenly there are no nursing. They're looking all depressed. So you have to start working pretty quick. First of all, that you have to do is be sure that we're not dealing with any neonatal encephalopathy, which could be something that is also happening on falls. Neonatal isoarthrosis, which is pretty much when the fall after ingesting the colostrum of the mom is going to start creating antibodies, and then going to be like destroying it, and then of course it's going to have a repercussion on the immunity system, and then the horse is going to be like affected because of that. So pretty much toxic mom's milk through the fall, in other words. So we have to separate and feed and separate for sure. So main thing with these guys on sepsis is be sure the depression is not too bad, but as we said before, the problem here is the horse itself. When there falls, their gut is open to get any type of immunoglobulins given through the colostrum. Now, a main thing here it will be FTP, or fatal partial transfer, right? FPT, because if we don't have an adequate colostrum, we don't have a good number of IgG in there, then certainly we're going to have issues. So a good recommendation for you as a practitioner or future practitioner, it will be like to consider to check your colostrum. So 24 hours of full already nursing, we should be anywhere above 400 milligrams per deciliter. If it wasn't looking lower than that, we are considered about fatal passive transfer, and certainly we need to stress addressing this as soon as possible. Another thing, the problem we have with these guys is since the gut is open because of the absorption of the colostrum within the first 24 hours and 48 hours, it will be the passing on other pathogens. In this case, the worst one is going to be E. coli, because that's the most common one, ubiquitous everywhere. But the problem with E. coli is that in a horse who has a non-mature immune system and an open gut, certainly can be like taking over the whole body. So we need to start working pretty hard, basically on the horse. Be sure that there's no other causes that we talked before. Be sure the umbilicus is fine. We put your iodine for pertuition. But a treatment basically is going to be supportive care, IV fluids, antibiotics, nursing care. Could be days in a hospital. It could be expensive. In some cases, we do vitamin E, vitamin C, and those are optional free radicals that we're going to put on there to start helping your falls as well. Injectables, prognosis, sometimes it could be 50%. Sometimes it could go up to 80%, depending on the initial evaluation, depending how bad affected we are. And I think there's a snap test ELISA to check your IgG levels. So get a little blood sample, get a serology, spin it out and get your sample and put it on your ELISA test and find out where we are with your IgG. But if your IgG is low, you need to start working on that right away. Some cases we have to even put a nasogastric tube and start like a PPN, TPN, and of course colostrum from another mother if that one is not really doing it. And supportive care, and just try to keep up with that one. Try to keep up with antibiotics to prevent beta-lactamase bacteria. Sometimes you have to even use aminoglycosides, which is a tough one, mostly because of the kidneys, but well, I mean, those cases you have to go rough sometimes. So keep it in mind. Just rule out the neonatal encephalopathy, wonderfuls, and if everything is ruled out, then start just going with this. Differential diagnosis will be hypoxic ischemic encephalopathy. But as I said before, just do a good physical reassessment. Thank you. All right, now it's time to talk a little bit about equine gestation, partition, and prematurity. So, equine gestation, partition, and prematurity basically is going to be something that we're going to be considering on the times. So, first of all, we need to understand the horses, they have a diffuse epithelial chorial placentation. So, that's something to keep in mind. And the gestation period on a horse is about 340 days, anywhere between 330 to 365. So in these cases, we can get a little bit of blood sample. We can check for serum progesterone and see where we at, if we're going to be close to the pertuition or not. But another physicians, they decided to look for waxing of the tails, waxing of the teeth, which can happen with the pertuition days too as well. So when we get close to pertuition, we're going to have more waxing of the teeth. So premature days, if we didn't have a prematurity or premature falls, typically they're going to be born in 310 or 320. So we're going to be short a little bit, like 30 days short. Typically the hair is going to be super soft. They're going to be soft cartilage on the muscles and ears, so be sure of that. Incomplete ossification, small cuboidal bones, lower weight, and joint tendon laxity. So these are fours that you're going to have to work on them really hard in ICU in order to make them work and come out of that. Pertuition, we're going to divide it in different stages. And basically we have a stage 1. That's basically when the fetus is in the birth canal. We have stage 2. And that's basically when the birth is actually happening. It takes about 20 minutes in stage 2, and the chorioallantoic membrane is showing up. And then stage 3, on that one, actually, you can see the fetal membranes coming out, so it's already given birth. And then one consideration that we need to have all the time is going to be the fact of retained placenta. Some veterinarians, they consider retained placenta to be at 3 hours, and this talk we're considered to be up to 6 hours. In order to start moving to another techniques to remove the placenta. Thank you. All right, one more. So we're going back to one that we did initially, which is laminitis, but this is just another type of review, but we're going to take a look at that pretty quick. So laminitis, as we talked before, could be acute presentation, it could be chronic presentation, but basically we're seeing a lot of loss of the hoof lamellar interface, and it is a very painful condition, you know. Even what is called a limb fracture can lead to laminitis, you know, after all this time. So we typically, on these cases, we end up recommending hoof testers, right, on the toe region. Remember, we've seen that before, using the hoof testers all the way around. And if we're not doing any diagnostics in particular, we're going to do the x-rays. Occasionally they can come out normal, but if we're doing the appropriate x-rays and the appropriate positioning, we find something. We're going to find originally what is called the rotation of P3, right? Which is the third pastern joint or the coffin bone. It's pretty much all the way to the end. So sinking of P3 inside the hoof capsule, that's a pathognomonic thing for laminitis. The position of the feet, the horse is going to be kind of like forextended on the limbs. 4 limbs is going to be forextended, and digital pulses are going to be increased too. So keep that one, those things in mind, because that's pretty important. So typically, clinical signs for laminitis: they're reluctant to walk, right? Prolonged recumbency, shifting weight, one foot more than versus the other one, and usually 90% of the time, it is basically 4 limbs. We can be predisposed to laminitis if We have situations like endotoxins, as we talked before, in the bloodstream, and the kind of endotoxemia, colitis, for example, pleural pneumonia that can make us laminitic. Support limb laminitis, the contralateral limb. Endocrinopathies, as we talked before, EMS, right? Equine metabolic syndrome or PPID, because the insulin, remember, insulin is a vasoactive compound, so that could be affecting. For example, bedding with black walnut shaving, horrible, that can cause laminitis. Grain overload. It's a good thing to ask always when you're having those cases to your client, what kind of surface your horse is living on. And grain overload and toxic black walnut, as we talked before, right? And as we said before, limb fracture could be one of those things. So I always expect digital pulses to be increased, because it's painful. Differential diagnosis for laminitis, we're thinking hoof abscesses or myopathy or pleuritis, any of those three. So be aware of that. It will be painful. It is acute. You need to help your horse. Help it out. Good, nice deep bedding. Good bedding. Take those walnuts bed to the trash and start using either like a soft cushion bedding, rubber mats, or rock dust. Be sure you're giving a little wedge. If he needs a shoe, you can put a bar, so prevent his sole to be like doing contact with the ground. So the bar is going to help to elevate it, and it's going to prevent it to start like bearing weight pretty much in it with the shoes. So if it is related to any of the other causes that we talked before, you need to fight your endotoxins. You can also give it a little bit of ice back on the feet where it's pretty hot. Put it on cold water. Start resting, which is the most important thing. Non-steroidal anti-inflammatory. Sometimes opioids is the worst case. Trimming, chewing, as we talked before. And see how they're doing. There's cases that they're pretty bad, and sometimes in some cases they have to do last resources, tenotomies, for example, the digital flexor tenotomy. That's something that we don't recommend typically. That would be the worst case ever. So just be sure that everything is fine, because as I said before, this condition can lead to digital ischemia, and that could be a situation. Hypoperfusion, vasospasm, thrombosis, those are things that can happen. So always keep it in mind. So comfort, support, be sure we're doing good diagnostics and rule outs, and try to support as much as we can. Thank you. All right, and the last topic for today is going to be colic. I think we did this at the beginning, but it's going to be just a last checkup on colic. So I have a little bit of extra information here for colic. So first of all, for females that they're on postpartum, so just got their fall in, they just did fall in, or they just got their fall a few days ago, it'll be one of the main causes of colic. So keep in mind that one. Once again, as we talked before, do your physical exam. Be sure the patient is not chalky. Be sure the patient is not having any dry mucous membrane. Be sure that exactly what is the pain level, as we talked before, because pain level is one of those main things. And put your hands on, Heart rate is going to go up. He's going to be breathing more. Abdominal pain could be seen. Can be more distension of the abdomen. The extremities could be cold. Remember, we talked about this before. A spasmodic colic or tympanic, you got a lot of distension. So there's a lot of pain inside. Bosque pain is one of those. So, as we said before, nasogastric tube, something that you have to consider. Plus minus sedation. If the dog doesn't let you the horse doesn't let you go in, use sedation, use your xylazine, give him some torp, and see how he does. If the heart rate goes down, they relax a little bit more. Nasogastric tube, as we talked before, try to pull anything out of there. If you start seeing that there's a copious amount, start raising your concerns about it, right? Depending how much we're getting out of there, nasogastric tube. If there's no reflex, and everything's to be okay, or at least in that part there's no reflux, we can attempt to start doing a little bit of electrolytes rehydration along with a little bit of mineral oil as well, and see that help. If we're concerned about horses that are older, small intestine, strangulation, colic is a concern, lipomas, right? Any kind of twisting of the large intestine, volvulus, postpartum, as we said at the beginning, it can happen on the female. We can always do our rectal exam. Same thing, you give him medication, you can do rectal now that he's more control on the pain. And you know, put your hands on, you know. You're gonna be checking the right, you're gonna check in the left. On the left side, check your pelvic flexure, simple impaction, dry feces, right there. You can see it right there. It's on the left side, right? Remember, on the left side we have the ventral column, dorsal column, we have the ilion that is not attached to anything, it's just hanging right there. And right there we have the pelvic fracture. But if you get to the rectal exam, you can feel it right there. So that's the first thing. Be sure that you're not feeling any possible distension on the right side, which will be a colonic distension, right? And remember this, if you're still seeing a lot of reflux, a lot of pain after a pain medication, the heart rate is not coming down, the treatment is not improving, you might have either a possibility to do an ultrasound, or you feel like there's distension, a possibility of rupture or fluid in the abdomen, you're going to have to refer this patient. Have to refer him for surgery pretty much. So prognosis depends case by case, either medical treatment that we can do on the field or surgical treatment. But if we're seeing, as I said before, no response to the pain medication and a large amount of fluid still coming down and no response to meds, we're going to have to refer this guy for something else. So keep it in mind anytime they work with colic. We don't want to deal with a perivital obstruction, large intestine pelvic fracture. Thank you very much.